All right. Well, thanks everybody for being here for my talk today for the Lunch and Learn. For those that don't know me, I'm Dr. Jamie Seabrook. I'm a professor in the Department of Epidemiology and Biostatistics, and I'm cross-appointed in pediatrics and food and nutritional sciences. And I've been part of the Human Environments Analysis Lab as a faculty associate since 2014. It's truly an honor and a privilege to be here. I can't say enough about the HEAL team and the collaboration that we do and the leadership of someone that I really look up to a lot, Dr. Jason Gilliland. So it's a pleasure to be here. My talk today is Hot Showers, Cold Reality, the Rise of Cannabis Hyperemesis Syndrome Among Youth. Just a show of hands before we start, who here knows about cannabis hyperemesis syndrome? Only because I talk about it. Hey, all right, fair enough, fair enough. Okay, all right, so I'm going to start just to give a little bit of context about some of my interest in substance use generally and cannabis use in particular, and kind of how it's led to this line of research now on cannabinoid hyperemesis syndrome. So back in 2017, one of my grad students, we published a systematic review on cannabis use and breastfeeding. I will say that in 2017, there was very limited studies. And basically what we found was that cannabis, especially in high consumption, can go into the breast milk. And obviously the infant is consuming that. And it's more problematic when the cannabis use is a lot, very frequent, and higher dose THC. And basically, we showed that it's associated with infant motor development problems in baby. And if someone is breastfeeding and they're using cannabis, they really need to limit the consumption if they continue the breastfeeding route as opposed to formula feed. In 2018, one of my grad students did a content analysis on Twitter, now called X. This is just pre-cannabis legalization in Canada. And we looked at pre and postnatal cannabis exposure and what types of messages were being conveyed. At the time, we knew that most women were turning to Twitter as the #1 outlet to get information related to cannabis and prenatal and postnatal exposure. Remember, this is pre-legalization. And essentially what we found is the vast majority, 77%, I believe, of messages that were being sent were very neutral in tone, neutral in the sense that, well, we don't know if it's harmful or not. But when you actually click the link associated with tweets, sometimes they had a link, they were more likely to report on the actual harms, whether that was having a low birth weight baby, effects on the developing brain, etc. In 2019, I did a study on predictors of cannabis, alcohol, and tobacco use during pregnancy. Dr. Gilliland was also part of that. And basically, we found that maternal depression was the #1 predictor of all three substances, cannabis, alcohol, tobacco. It was more important than income. It was more important than education. It was more important than maternal age, for example. So mental health really driving substance use during pregnancy. In 2020, we published work on teen pregnancies and the influence of cannabis, alcohol, and tobacco and its association with birth outcomes. We had over 25,000 pregnant women from London Health Sciences Center. And basically what we found was that teens that were pregnant and had their birth outcomes, they came from greater areas of neighborhood socioeconomic disadvantage. They had worse mental health problems, both depression and anxiety. And they also had greater use of these substances during pregnancy than non-teenage pregnancies, adult pregnancies. In 2021, we went on and did work on vape and poly substance use in university students. This was also very heel run. And basically we found that there was a strong link. Very few people are just using cannabis alone. There's a lot of poly substance use occurring with vaping, with alcohol, with cannabis. Interestingly, with cocaine at Western, there was a fairly large percent reported that. In 2022, we looked at residential greenness and patterns of substance use. And essentially, kind of interesting, we found that in areas of greater greenness, this was nationally representative data in Canada, alcohol use, specifically binge drinking, went down, which kind of makes sense. So more greenness, less binge drinking, less vape use. But interestingly, cannabis consumption went up. And when I had a talk with my daughters, they're not involved in this substance use, but they predicted that would be the case because they said, now, Dad, what's happening is with cannabis use, they're going to areas like parks at night and doing their cannabis and then coming home. So that's what we found. In 2023, we looked at prevalence of vape use, including cannabis vaping in Canadian high school students. And we found that 1/3 of Canadian adolescents, this is nationally representative data, 1/3 are using their vape products to consume cannabis. In 2024, this was largely the work of Kelly Anderson, who Dr. Gillian and I collaborate with from time to time. She looked at the impact of non-medical cannabis legalization on health service use on cases of psychotic disorders, and basically found that in the short term, the relationship was not there. But when you looked at trends over time, there was higher rates of psychotic disorder associated with cannabis use. And then lastly, in 2025, Dr. Sharon Zong led this, and with our HEAL team, he looked at geographic accessibility to cannabis, alcohol, and tobacco in Ontario. And over time, essentially found that cannabis outlets, no surprise, have kind of gone off the charts. Alcohol outlets also went up, and tobacco did not. So all of that kind of leads to my talk on cannabis today. So I just want to say, as an introduction, this really is a growing global health issue. And these statistics may surprise you, but it's the most up-to-date we have. In 2024, the Canadian Cannabis Survey showed that 41% of Canadians, just between the ages of 16 to 19, so what we could call higher level teens, reported using cannabis in the past 12 months. And 1 of 5 were using it in the past 30 days. That's typically what the literature calls current use. And 9%, perhaps even more alarming in my view, were using cannabis every single day or close to it. So that's almost 1 of 10 between the ages of 16 and 19. For those online, we've ordered pizza, so no, I won't be offended if you get up and go get pizza, everybody. Go for it, okay? One of the biggest concerns associated with cannabis today is the increasing potency of THC. So I always struggle with, research that tries to compare, say, cannabis use in youth in the 1980s compared to today, because it's really an apples to oranges comparison, because the THC levels were very low at that time compared to what they are today. How much? Well, it's increased by over 400%, from 3% THC potency in the 1980s to, according to Health Canada, an average of about 15% today. Every youth I've ever talked to said no one's using 15%, it's way higher. And sure enough, some strains are as high as 30, I would argue higher than that. And that is really, really problematic because of the developing brain. So we know that the brain continues to develop till approximately the age of 25. And this THC exposure, especially chronic exposure, very frequent exposure during these critical periods when the brain is still developing can result in long-term cognitive deficits. That includes issues with attention, memory, and learning. And some of our more recent research also shows that it's also associated with higher risk of depression, anxiety, psychosis, self-harm, and cannabis use disorders. So this is really, really, really problematic. And as like I said before, it's often associated with polysubstance use as well. So a small percent are only using cannabis. So a growing concern associated with this high potency cannabis use is what I'm going to talk about today, cannabinoid or cannabis hyperemesis syndrome. And this is a gastrointestinal condition that affects individuals who use cannabis essentially a lot. And by a lot, most typically in the literature, daily to weekly. All right, so it could be at least in the past week, but quite often more than that. And not just at one point in time, but over a long period of time, including several months to years, more typically years. And it's characterized by a severe and persistent vomiting for hours or days. Chronic nausea gets worse with cannabis use, abdominal cramping, and temporary symptoms. I'm going to talk more about that, hence my title, from very hot showers or baths. And, you know, obviously here right now at the HEAL Lab, we do a lot of, vast majority of research on youth. And interestingly enough, youth are disproportionately have higher odds of developing cannabinoid hyperemesis syndrome, although people of all ages can get it. And the interesting thing is that many clinicians and cannabis users themselves don't even know about cannabis hyperemesis syndrome. And this really highlights the need for increased education and awareness. So I have really two objectives today. The first is to provide a clear and up-to-date overview of CHS, including its symptoms, its diagnostic challenges, phases of the condition, physical and mental health impacts, nutritional concerns, and very common misdiagnoses. And the second is to offer recommendations moving forward with respect to prevention, early education, diagnosis, clinical intervention, community support, and policy, and really to advocate for new areas of research and advocacy, which I'll talk about. The next point I really wanted to make is that, you know, I'm talking about this, but we have very, very limited research on this topic. Myself, my daughter, Morgan, who was disappointed she couldn't make it because we had the one vehicle and the weather, but she's going to hear it online. And Dr. Gilliland, we published a paper this year on cannabis hyperemesis syndrome, and it was a narrative review. And what we found was up to March 2025, it was published like the spring, but up to March 2025, there was only 13 original articles on cannabis hyperemesis syndrome in youth. And, you know, those included, but hold on to that thought for a second, RCTs, observational studies, case reports, case series, and qualitative research. But yes and no, 9 of the 13 were simply case-based studies. And that includes 6 being case reports, 3 case series, 1 RCT, which I'll talk about, which basically compared 2 drugs and its impact on the cyclic vomiting, 1 longitudinal analysis, and 1 repeated cross-sectional study, 1 qualitative study, spanning the years 2004 to 2024. I will just say right now in Canada, there is no original research on this topic in youth, literally 0 as of this year. Not to pat ourselves on the back, but we got a lot of media coverage on this. CBC News, Free Press, front page of the National Post. And it was interesting because when I was doing a lot of these interviews, I'll just say it this way for purpose of a presentation. It was interesting and alarming to hear people after the interview say to me on more than one occasion, I think that's exactly what my child has. Can we talk for a few more minutes? Sure. And I'm going to get into all of this in this presentation, but they've been into Emerge, they've been seeing their family physician, they've never been asked about their cannabis use, they've never been asked about cyclic vomiting, but we'll get into common misdiagnoses and treatments in a moment. So here's what we know and here's what we don't know. The first is there is literally zero evidence to support the idea that just using cannabis one time can trigger CHS. And it's chronic use, typically over many years, and frequent use. And we also don't know why some people develop the condition and others don't. You know, whether there's a genetic vulnerability associated with it, along with the substance use. And we don't know why symptoms manifest earlier in some people than others. So that's kind of our knowledge base. So let's turn to some of the symptoms. And the reason why I'm saying 2004 to present is we didn't even know what in the world CHS was in 2004. It was the first kind of, we'll call it pioneering study by Allen et al. And at that point, again, they didn't know what CHS was. So what they did is they reported on 10 people from South Australia who was experiencing this cyclic vomiting. Sorry if you're eating. And should have thought of that. Change it after. Attributed to chronic cannabis use. And interestingly, what they found in their sample size of 10 people was that 9 of them sought relief from multiple hot showers or baths during the acute phase of their illness. That is when they're experiencing this cyclic vomiting. And those symptoms resolved in 9 of 10 people like that when they stopped using cannabis. Now, that was 2004. Interestingly enough, the first reports of CHS didn't come out in Germany until 2011, Puerto Rico in 2015. And we know that between the years 2017 to 2021, emergency department visits doubled in both the US and Canada with symptoms related to cannabinoid hyperemesis syndrome. And here's the real paradox, because some people will say, yeah, well, cannabis is often used to treat nausea. But what you have to catch is that low doses of cannabis use can reduce nausea, but interestingly, high doses and frequent use can lead to CHS. So in addition to this, debilitating abdominal pain, excessive vomiting, we know can lead to dehydration, to electrolyte imbalances is really bad, and to disorientation. And going back to my title, one of the key features of CHS is the compulsive need for hot showers or baths to relieve symptoms. This is a learned behavior. It's not a mental health issue. It's a learned behavior when they're experiencing the cyclic vomiting. They have a hot shower, oh, it's making me feel a little bit better. And often they're back in, they're out. They're back in, they're back out, many times during the day. However, the best treatment is simply cannabis cessation, stopping cannabis. This is a temporary relief, these showers, temporary fix. In fact, a systematic review, but catch this, of case reports. So we think, oh, we already got systematic reviews of case reports because there's very little original research of observational studies, found that about 97% of people who stopped using cannabis experienced complete resolution of their symptoms. although they can reemerge within a 24-hour period after the last use. Now, diagnosing CHS has not been easy. It's diagnosed under the Rome 4 criteria, which includes a lot of what I've been talking about: prolonged and excessive cannabis use, cyclic vomiting, resolution of vomiting episodes when you stop using cannabis, and often, again, that very compulsive need to have hot water on your body. In other words, diagnosing CHS is very much related to the symptoms they're experiencing. So if someone goes into, for example, pediatric emergency, and I'm a emerge doc and I ask about substance use, I would argue, most don't ask about substance use, but I would argue if I did and I asked and I say, yeah, I'm using cannabis, is how often do you use it is a key in a non-judgmental way. How long have you been using it? And this key question about hot showers and baths is paramount, or you might think it's something, which we'll talk about later, called cyclic vomiting syndrome, which is not this. So, although considered rare by clinicians and cannabis users, the issue is it's frequently misdiagnosed. It's, for example, some will think maybe it's gastroenteritis or it's cyclic vomiting syndrome. Just to give you a quick snapshot of the latter, cyclic vomiting syndrome is unrelated to long-term chronic and frequent cannabis use. It's basically, we're not sure what the pinpoint silver bullet factor is that's causing it. Whereas, of course, cannabinoid hyperemesis syndrome is very much related to chronic and frequent use. And diagnosis in the literature has been shown to be very costly and lengthy. Lots of CT scans, MRIs. You know what, everybody, we're not finding anything. I'm going to send you home gastric emptying test. I could have thrown colonoscopies in that. Sometimes we'll say, you know what, maybe it's something in your diet. Take this out of your diet. But no questions related to cannabis use, frequency, and chronic use, which is not getting at the issue. So given all this, youth with cyclic vomiting should be screened for cannabis use and compulsive hot bathing. It would solve things very quickly. And for those who continue using cannabis, despite cannabinoid hyperemesis syndrome diagnosis, referral to an addiction or substance use services may be needed. And, I have to say that begs the question, is cannabis use more addictive than we previously understood? Because if we have people that are using it daily and can't stop, and I hear a lot of people, well, cannabis isn't addictive. Well, if they're using it every day, they're quite addicted to it or close to it, right? Okay, so how does it ever come about? There's really three phases. There's the prodromal phase, there's the hyperemetics phase, and the recovery phase. The prodromal phase, as we'll talk about, the first stage, they're not experiencing the cyclic vomiting yet. And this can last for many months. And they may experience morning nausea, feeling like you're going to get sick, hence a fear of vomiting, and a lot of, abdominal cramping. And the interesting thing is most will continue using their cannabis thinking it's going to help relieve the nausea because a lot of their friends are saying, yeah, this will make you feel better, right? During this prodromal phase, dietary habits and body weight are typically maintained. And why? Because they're not, I'll just say this, they're not regurgitating their food when they're eating, right? Because they're able to, they just feel abdominal cramps and a lot of nausea. But during the hyperemetic stage, now the very persistent cyclic vomiting kicks in. And so does the intense abdominal pain. And this usually lasts extremely hard for 1 to 2 days. Additional symptoms are hot flashes, sweating, trembling, a high rise in blood pressure, weight loss, which makes sense because just going to say it, if they can't keep their food down, right, they often lose weight. And of course, the big medical concerns is this can lead to dehydration and electrolyte imbalances. And it's during this phase where everything kicks in, the cyclic vomiting, the extreme abdominal pain, that they have this learned behavior where they realize that there's something that helps me momentarily, and it's the hot water, hot bathing. However, these symptoms will return when the water cools. So if you ever, I don't know, having a hot bath and then all of a sudden you're laying in it relaxing, or after a while it cools, then you want to crank up the temperature again to make it even hotter. Or when they leave the hot water, so they get out, get changed. Oh, I feel terrible again. And the recovery phase is the third phase. And this is really marked by a return to normal bathing habits and regular eating. And they experience weight gain. Why? Because they're in the recovery phase. But a key challenge is the abstinence, because we know best treatment is stopping cannabis altogether. And this abstinence isn't easy. You picture this, you have someone who's using it every single day, and a healthcare provider says, here's what you have to do. You need to stop cannabis completely, which is why London Health Sciences Centre has adopted a harm reduction approach, which is basically, those who know, it's basically going, let's meet, Michael right where he's at, find out how frequently he's using cannabis, and see if we can get that down to maybe, instead of every day, let's get it down to 3 days a week and maybe once per week, and trying to, rather than just saying you have to quit altogether, right? Because that obviously often can lead to relapse. There's a lot of physical health impacts as well. Obviously, the unintended weight loss because they can't keep the food down. Severe dehydration, I already mentioned that. Acute kidney injury is not unheard of by any stretch of the imagination. And another real big issue is that research shows that they present frequently to the emerge and can be hospitalized multiple times per year. And you could picture that's physical, but it's also mental, because if the healthcare providers are not asking about their substance use, here they are, that inpatient stay, they went home, we start the process all over, just going around the mountain over and over and over. And research also shows that in rare instances, cannabinoid hyperemesis syndrome can lead to death because of electrolyte imbalances resulting from all this chronic vomiting. I think it's fair to share this. I won't, but when I gave my grand rounds for this, someone had raised their hand and said, wow, do I appreciate this research? Everything you're saying was my daughter. And if you don't do the research, someone has to soon. And was worried about the latter bullet point. So there's also a lot of mental health implications with CHS. Obviously, the emotional strain associated with frequent vomiting and dehydration can increase anxiety, isolation, and depression, especially when individuals are unaware that that's the underlying issue is their cannabis use. Because again, many are using it under this false belief that it's helping to relieve their symptoms, but it's doing it, it's actually exacerbating their symptoms. And these, depressive and anxiety symptoms can worsen when healthcare providers themselves are unaware of the condition, or maybe they're aware and they don't ask about their chronic and frequent use. And it leads to repeated emerge visits, long hospital stays, etc. Now, sometimes in research we say, the chicken or the egg. We say, well, sure, cannabinoid hyperemesis syndrome can make mental health way worse, but sometimes people will have poor mental health at baseline and will turn to cannabis as a coping strategy. But even still, it's been shown to exacerbate symptoms of mental health problems, be it depression, be it anxiety. Research shows that. And here, if we look at this figure to the right, some of the impacts are slower processing, lower verbal comprehension, poor memory, less control of emotions, worse problem-solving skills. Again, not to doom and gloom. This is very much high-potency THC, long-term and frequent use that increase this risk. So the cognitive impairment linked to CHS could be aggravated by them experiencing all of this cyclic vomiting, their dehydration, and all the stress about going in. And, I keep going in, I'm not getting any answers. There must be something, really bad wrong with me. And then I get a CT scan, MRI, everything looks good, everything's negative, back you go home. And interestingly enough, the physical and psychological impacts of CHS may actually lead to more substance use because their mental health is getting worse, their physical health is going worse. I need a coping mechanism. So we have to be careful, I always say as researchers, to point fingers and say, you're just making the wrong choices, but you have to understand when they're not getting answers, they often get desperate. And there's also the fear of judgment from family, friends, and healthcare providers, which discourages some people from seeking treatment. I will say the literature is clear that since legalization of cannabis up to now, 7-ish years, they're more likely to report their cannabis use if asked because of growing acceptance of cannabis, which is a good thing. But the cyclic vomiting and whatnot, and can't keep food down. It's a lot for someone who's to relay all that information to a healthcare provider. So both CHS and long-term cannabis use on its own, or even without CHS, can independently contribute to difficulties with attention, with memory, emotional regulation, making it hard for affected individuals to recover or to actually to adhere to the recommendations that are given to them by their healthcare provider. Interestingly, when we think about early intervention and preventive education, there is no overarching evidence-based treatment protocol for CHS. None. There's been guidelines, various guidelines which differ, but they tend to be centered around let's rehydrate the patient, right? Because of them being very dehydrated from all the vomiting. Let's give some supportive patient education and counsel to stop the use of cannabis. That seems easy enough, but when I also hear, from some of the people that Dr. Gilliland and I are collaborating with, that we're not trained mental health experts. So it's easiest for us to go, well, they need to do this, but that's not their area. And naturally, we try to shy away from areas that is not our expertise. And some combination of psychosocial interventions and pharmacological treatments for managing. But regardless, early recognition of CHS is paramount so that we don't lead to severe dehydration and fluid imbalance, which is far more likely when they get no answers. That makes sense so far? So what type of education do we need? We need targeted education in schools. We need in healthcare settings as well. And we need public health campaigns about the dangers of chronic and long-term and frequent cannabis use. There's still a lot of misconceptions out there. Now with cannabis outlets being on every corner, we think there's no issue with cannabis. Everyone's doing it. And the idea that it's not addictive. This can delay diagnosis, it can delay treatment, It leads to repeated emerge visits and way too many waste of healthcare dollars and unnecessary medical testing. Interestingly, when we look at what we do know with respect to early recognition and treatment, someone will typically come in and they'll immediately, very typical in emerge, get hooked up to an IV to get them hydrated again, and some anti-nausea meds. However, conventional antiemetics have shown little to no relief. They don't work. There is some evidence that topical capsaicin, sorry, I'm not a physician, can reduce nausea when applied to the upper abdomen. And we also know that short-term use of anti-anxiety and antipsychotic medication can be beneficial, short-term use. In fact, the only RCT we have, that was one of the 13 studies that we looked at, compared low-dose haloperidol is how you pronounce it. For those who don't know, that's an antipsychotic, often used to treat psychosis or schizophrenia. It was better than ondansetron in reducing nausea and reducing pain and any need for extra medications. It also led to an earlier discharge. It was a small sample size, but that's the only RCT we have. Hospital admission may resolve CHS simply by ensuring cessation, meaning that if you're hospitalized, well, you're not using cannabis during your inpatient stay. So those symptoms go away. Again, if the healthcare providers are unaware of CHS, they go home and the process starts all over again. So immediate cannabis cessation can also cause withdrawal and relapse risks, requiring patient discussion. So what are some of our primary care public health roles here? Well, the first is that healthcare providers should really be providing cessation discussions with a harm reduction approach. Again, meeting someone right where they're at and saying, instead of saying you need to quit right now, saying where can we meet you and gradually start to reduce the amount of substance that you're using. And recognizing someone's resistance to reducing even their cannabis use can serve as a really obvious indicator. This is chronic cannabis use, and they may very much have a cannabis use disorder. So what are some of the healthcare and societal benefits of early intervention? Well, the first is the earlier that we can intervene in these people's lives, well, we prevent unnecessary tests and procedures, and we save the healthcare system a considerable amount of time and resources. And providing a diagnosis early can increase the likelihood that these people acknowledge that, yes, in fact, my chronic cannabis use is a major issue, and help them make a more informed decision about reducing or ideally even stopping their use of cannabis altogether. So by fostering this awareness among youth, parents, and educators and healthcare providers, these emergency visits can be minimized, and we can get them the appropriate care that they need. Again, I'll just say this, that it seems like it's maybe not as big or common as we think, but I'm not sold on that based on what we know in the literature right now. And the fact that, I'll just say this, 3 out of 10 interviews that I gave, they stayed on the line and they wanted to talk to me about it, because if it wasn't their child, they knew someone who had these. There's 3 out of 10 from CBC, which is very, very, very interesting. So there's also evidence research about how we enhance disclosure among youth and their cannabis use. Because we know that a lot are very reluctant to talk about it. So one evidence-based recommendation is for healthcare providers, be it a nurse or an emerged physician, for example, to get training on how to approach these sensitive topics. Because it's very easy to have the idea or the mindset, this isn't my area, so I'm going to avoid it altogether. Well, that's not helping the healthcare system. I would argue, as evidence grows, it's probably not doing your job correctly. And we need to be aware of these issues, especially in line of, as I mentioned before, to some of you heard this, Dr. Gillian and I were in a Zoom or a Teams call where someone said, today, greater than 50% of everyone who comes to the Peds Emerge has a mental health issue, and we're just not prepared to deal with it. Well, we can say it's not my area and ignore it and see those numbers continue to climb, or we can get the training that we need. So, for example, have you been using cannabis or other substances recently is a lot different than implying blame or judgment, like how much cannabis have you been using? You see the difference in how it's worded? So when youth feel their healthcare providers are actually there to listen and provide support, some of the work, hopefully, that we're able to get going sometime soon with our new SNAP project, they're more likely to be open and honest about their cannabis use or substance use generally. Now, this next piece is I also find very, very fascinating from a nutritional perspective. So when patients are hospitalized with CHS during their hyperemetic stage, this is when they're experiencing all the cyclic vomiting. Again, treatment typically involves the IV. Make sure you get them hydrated, which the longer they've been dehydrated, the worse. And naturally, withholding all food and beverages because we know that they're not going to be able to take the food and beverage down. And gradually reintroducing liquids and foods as symptoms start to improve. However, if they're being treated at home, the importance of glucose and electrolytes are really valuable because they need to stay hydrated. And as these symptoms improve, introducing very bland foods and digestible foods such as broth, rice, toast becomes very important so that they're able to keep, some of the food down. Eating disorders, this is a really, really interesting area where there is some, very minimal, but there is research showing that some of them are being misdiagnosed with an eating disorder. And that makes sense because of the purging, right? So they're eating food and within X amount of minutes, they go to the toilet and they purge. Very much characteristic of what we would call an eating disorder today. I have done some research on eating disorders, and the one that really it overlaps with would be bulimia nervosa. And this is when people have difficulty controlling how much food they're eating, and they go and they would purge thereafter. But that's not CHS, because CHS vomiting is involuntary and there is no body image concerns. Whereas if you have bulimia nervosa, the vomiting becomes voluntary and there is quite frequently very high body image concerns. And what makes this kind of even a more trickier piece is over 1/3 of people who have a substance use disorder also have an eating disorder, to even complicate the process more. Again, a lot of this very much linked to everything that's on our board here at HEAL, mental health. And we also know that people who have CHS tend to go back to their normal eating behaviors again once they're symptom-free, which differentiates it from the typical eating disorder, where it's a much more chronic and ongoing. So let's turn to some discussion and next steps. The first thing I want to say is that although cannabinoid hyperemesis syndrome is becoming more known, evidence remains of low quality. Remember that 9 of the 13 papers that we looked at were case series or case reports. That's very low. If you look here on the little hierarchy of evidence, it's right near the bottom. So the vast majority are drawn from right near the bottom in terms of the hierarchy of evidence. So we need better quality research. We need prospective epidemiological studies. We're in the process of moving forward with that. I hope 2026, we, fingers, toes crossed, we'll have our first, if it's not already being done, first study in Canada, original research done on this topic that we're proposing to do in the Emerge. We need adequately powered studies, not a case report of 7 people, and RCTs that help establish treatment protocols. And we're already kind of putting that in place as a potential idea once we get this original study up and going. And I would argue that regardless of one's belief about how common or not it is, we don't even know that in terms of prevalence, it's likely going to go up as cannabis becomes more widespread. You wouldn't think it's going to go down when you can turn left and turn right from your house and find a cannabis outlet. And hence the importance of geography. I always say this as a joke, but it's very true. When I became a professor in foods and nutrition, everyone was, you are what you eat. And I love what Dr. Gilliland told me. He said, you are where you live. Where you live matters too. So we want to think about that with respect to geography and accessibility to cannabis outlets and getting it online. So in managing CHS, we need greater awareness, not just among Emerge docs, but among gastroenterologists, neurologists, and psychiatrists. And we need more public health campaigns that raise the awareness among cannabis users, helping them recognize the risk of using cannabis long-term and very frequently, given the high potency of THC. I will say, normally when you get a little bit of media coverage, you got to watch what you read if you read it all on the comments. I will say 95% were like, more needs to come out on this time, which was interesting. The 5% that didn't, when you search, is they were high cannabis users, right? They use it all the time. We also know very little about the pathophysiology of CHS, and we need more basic science that goes, what are the underlying mechanisms that contribute to CHS in youth? And we need to learn more about the role of the endocannabinoid system, whether there's a genetic predisposition, or sometimes we'll call it genetic vulnerability associated with CHS, and if there's any potential biomarkers that could help improve our understanding. Someone came up that a friend of Dr. Gilliland and I, Dr. Doug Fraser, someone who works with Dr. Fraser, came up to me and said, oh my goodness, this would be an amazing line of research where we could probably think about getting at some type of biomarkers. But again, we need those initial studies first to kind of set this in motion. So that basically wraps up everything that I wanted to talk about today, and hopefully you learned something. I'm open to questions, and thanks so much to Dr. Gilliland and the HEAL Lab for all their support.
Question. So you may not know the answer to this, and it may not be the most relevant, but do they know why the warm showers and hot baths helps with the symptoms? Because when I think about people being nauseous, it's not something that you would normally turn to that would be effective. So what's different about this disorder that it helps alleviate some of the symptoms for?
All I can say about that, Shauna, is no, they don't know. And there's many competing hypotheses, but they're not sure about any of them at this point.
Being that you mentioned has like a burning sensation.
Yeah.
So it must be something to do with the heat on the skin. It must be.
That's
it
what
must be, but I presume that
that's one of
relate to sort of nervous endings and
that's
like pepper kind of that comes
Yeah,
together. Whatever. Yeah, it's in hot peppers.
Yeah,
So
that's I would say at this point what they're assuming, thinking, leading to. That's helping them, at least temporarily.
And actually, it's interesting your point. and get to your bed. There you go. Wonder what started that. Is there a sort of a desire to get into water? Is there some sort of mental component?
There's no evidence for that,
Yeah.
that I've read about. It's just, well,
You
people-
try it and then
Yeah.
you feel better, but
Yeah.
I wonder-
and then that heat just keeps going, like burning hot.